Hi, it's Patrick Hutzel from IntensiveCareHotline.com, where we instantly improve the lives for families of critically ill patients in intensive care so that you can make informed decisions, have peace of mind, real power, real control, and so that you can influence decision making fast, even if you're not a doctor or a nurse in intensive care. This is another episode of Your Questions Answered, and in last week's episode I answered another question from one of our readers, and the question last week was, how can my mum with tracheostomy have quality of end of life? You can check out last week's question by clicking on the link below this video. In today's episode of Your Questions Answered, I want to answer questions that we get quite frequently as part of my one-on-one consulting and advocacy service, and today I want to answer questions about tracheostomy in children or tracheostomy in kids. Over the last decade, and probably even a bit longer, tracheostomy has been increasingly performed in children, aligned with the improvements in neonatal and pediatric intensive care. Nowadays, the majority of children with tracheostomy represent a very complex cohort of patients with sustained reliance on tracheostomy and related medical technology for long-term survival. So what is a tracheostomy? The term tracheostomy is used to describe a surgically created hole in the neck that extends to the trachea or windpipe to allow for safe breathing. A tracheostomy tube is the plastic breathing tube that is placed into the hole. So why would your child need a tracheostomy? Your child's doctor will talk with you about why your child needs a tracheostomy. The length of time your child has a tracheostomy tube depends on the reason for the tracheostomy tube. The tube helps breathing and helps clear mucus from the airway. The more common reasons for a tracheostomy are listed here. A blockage in the upper airway. If the upper airway is blocked, air cannot get into the lungs. The tracheostomy tube helps your child breathe. Paralyzed vocal cords may also block the upper airway. When the vocal cords do not open, air does not get through and the child cannot breathe. The tracheostomy tube lets the child breathe normally. Other conditions that may block the upper airway include polyps, narrowing of the trachea, or weak muscles in the trachea. When the muscles in the trachea are weak, the trachea closes and blocks airflow. Next, inability to clear mucus from the lungs and airway. Lungs make mucus. Mucus cleans the lungs by picking up tiny bits of dirt and dust. Cilia, which lines the lungs, help the mucus carry the dirt and dust out of the lungs. This protects the lungs from irritation and infection. Some children are not able to cough mucus out of the lungs and airways. If mucus stays in the lungs, the child is more likely to get infections. The tracheostomy tube provides a way to help clear mucus from the lungs. Next, it is long-term help with breathing. A tracheostomy tube is put in when a child has to be on a ventilator for a long time. Your child may have to use the ventilator at home after the tracheostomy is placed. There are many reasons why a child may need long-term help with breathing. You need to discuss this with your child's doctor, and if your child does need help at home with breathing with a ventilator, you should check out intensive care at home services, and you can find that at intensivecareathome.com. Next, is a tracheostomy permanent? For most children, the tracheostomy is not permanent. The length of time it stays in place depends on the individual patient and the reason it was placed initially. Although some tracheostomy tubes stay in place for many months or years, many are temporary and can be removed after a shorter period of time. After the tracheostomy tube is removed, the hole frequently closes by itself. If it doesn't close by itself, the hole can be surgically closed. Tracheostomy procedures in pediatric population. Let's look at that next. Differences in pediatric and adult upper airway. Kids are not small adults. When planning the approach for tracheostomy placement in infants and children, it is important to first address the differences in adult and pediatric laryngeal anatomy. Both anatomic and physiologic characteristics of the infant trachea require special surgical techniques and adequate post-operative care. If you scroll down below this video in our written version of this blog, you will find some pictures about the anatomy of pediatrics and adults when it comes to the trachea. And if you are watching this on YouTube, just click on the link below this video. Infants have shorter and fatter necks than adults. The adult larynx is positioned at the 6th or 7th vertebrae. The hyoid frequently overlies the thyroid cartilage notch, making palpation of anatomic landmarks difficult at times. The infant thyroid membrane is also much shorter. The cricoid cartilage is the narrowest part of the airway in a child. In adults, it's the vocal cords. Physiology. The cartilages of the infant larynx are softer and more pliable than in adults, with a tendency to collapse if pressure is placed on them. The mucosa of the supraglottis and the subglottis are lax in infants and thus more prone to edema when inflamed or injured. Indication. It is important to be aware of the indication for placing the tracheostomy in a child if a tracheostomy is being placed for upper airway obstruction secondary to abnormal anatomy, such as subglottic stenosis or complete tracheal rings. Entry into the airway may be difficult, with risk of damage to the posterior tracheal wall. So how is a tracheostomy performed? The tracheostomy procedure is performed in the operating room under general anesthesia. A small incision is made in the skin overlying the trachea in the middle of the neck. The surgeon exposes the airway and makes a small incision into the trachea. The tracheostomy tube is placed in the hole and secured to the neck. What are the effects of a tracheostomy? The specific effects of the tracheostomy tube will depend on the age of the child, the reason the tracheostomy was placed in the first place, and the need for long-term ventilation. It is important that you discuss your child's tracheostomy and the effects of the procedure with your child's surgeon. When a tracheostomy is present, care must be taken to prevent water or sand from getting into the tracheostomy tube, so no swimming is possible. As a general rule, the tracheostomy tube will not keep your child from being able to eat normally or use their voice, although some children may not be able to eat orally or speak for other reasons. Many children with a tracheostomy tube are able to lead very happy lives. So what are complications of tracheostomy in children? To ensure adequate function of the tracheostomy and to minimize potential complications from the tracheostomy, proper care and maintenance is important. Adverse related tracheostomy events can be divided into those occurring early, including the perioperative and immediate postoperative period, and delayed. It is important that adverse events be quickly recognized and addressed to prevent devastating consequences. What are early complications? Early complications are air leaks, pneumothorax, pneumomediastinum, or subcutaneous emphysema. These complications are most often caused by technical errors during surgery. Despite all precautions to prevent these complications, they still may inadvertently occur. A chest radiograph should be routinely performed when the child returns to the ICU following tracheostomy to check the status of the chest. Injury to surrounding structures. The cricoid cartilage and tracheal landmarks need to be clearly identified before making an incision into the trachea to prevent inadvertent incision into the cricoid cartilage, which could result in subglottic stenosis. Injury to both the esophagus and recurrent laryngeal nerves has also been reported and can be prevented by careful surgical technique. Esophageal injury is also more likely to occur if there is a nasogastric tube in the esophagus, with the esophagus being accidentally mistaken for the trachea. A false passage may be easily created upon initial insertion of the tracheostomy tube, especially if the incision in the trachea is too small or the tube is aggressively pushed against resistance. Posterior tracheal lacerations may be caused by a similar method. If the tracheostomy tube is the incorrect size and is too large, it may cannulate a main bronchus. It is important to always assess the position of the tube in relation to the carina with a flexible tracheoscopy immediately after it is placed. Another complication is airway obstruction, because at the end of the day, a tracheostomy is an artificial airway. Next, mucus plugging can be prevented by adequate humidification. Tracheostomy cares with routine suctioning. Constant supervision of a child with a tracheostomy tube is requiring to prevent plugging, and also regular normal saline nebulizers will help. Next, delayed complications. Accidental decannulation can occur in the immediate post-operative period, and the consequences may be tragic. It can commonly occur as the patient is being moved from bed to travel to ICU. The presence of stay sutures, especially in a very small infant, will help with replacing the tube through the fresh stoma. Accidental decannulation can be prevented by correct tracheostomy tube selection and placement, ensuring that the tube is adequately secured, and by stable patient positioning. Next, stomal problems. And next, granulation tissue develops secondary to the friction and movement of the tracheostomy tube or chronic inflammation. It usually responds to local wound care and more frequent tracheostomy tube and dressing changes. Treatment is topical antibiotics, and steroid ointment is sometimes required. Occasionally, silver nitrate cautery is required to control granulation tissue. Tracheocutaneous fistula. A tracheocutaneous fistula may develop when a tracheostomy orifice epithelizes during a prolonged course of healing or undernutrition. Tracheal lesions. Suprastomal granuloma, suprastomal collapse, and subglottic stenosis. Hemorrhage. Perioperative and postoperative hemorrhage may be prevented by meticulous attention to hemostasis throughout the procedure. Bleeding often stops spontaneously but can occasionally persist. It is important to address it with cautery before the tracheostomy tube is placed. Coagulation abnormalities should be ruled out in any child undergoing tracheostomy, especially those with chronic liver disease and thrombocytopenia secondary to sepsis, and abnormalities should be corrected before surgery is possible. Tracheoesophageal fistula. The TEF is another complication among patients with tracheostomy tube. This complication is due to high cuff pressure or direct mechanical trauma. TEF is very rare. Its rate of incidence is about 0.5%, but we also know of some patients that are born with a tracheoesophageal fistula. Next, swallowing problems can occur as well. Let's now look at newly formed surgical tracheostomies. Stay sutures are placed in all surgical tracheostomies. They are placed through the tracheal wall on either side of the midline and left long, secured to the child's chest and labeled left and right with do not remove or stay sutures, and are to remain in situ after the first tracheostomy tube changing, day 5 to 7. In the event of an emergency tube change during this period, traction is applied to the sutures upward and outward to hold the stoma open to facilitate the insertion of a new tracheostomy tube or endotracheal tube. Next, placement of children with tracheostomies. Children normally recover from the surgery quickly. Your child will need to stay in an intensive care unit to make sure the first tube can be safely changed, normally between 5 and 7 days after surgery. Once the tube has been changed without any complications, your child will be transferred to a hospital ward, but only if they're not ventilated. But there are cases that children will need to stay in the ICU indefinitely because of critical airways and mechanical ventilation. Your child with tracheostomy can actually go home with services like intensive care at home, where they will be looked after 24/7 by a team of highly skilled, highly experienced critical care and intensive care nurses. Cut the cost of an ICU bed by 50% and provide your child and family with better quality of life and provide a win-win situation. You can check out intensivecareathome.com for more information. Now, patients and families couldn't be happier to finally leave a burdensome stay in intensive care and go back to their lives at home with 24-hour specialized intensive nursing care at home. Our clients, whether they be children or adults, can actually go back to school, can go back to kindergarten, whatever their normal life activities are, because they've got the specialist care at home around the clock with intensive care at home. And that doesn't stop them from going back to their lives and to the things they want to do. Tracheostomy in Kids Part 2 will continue in next week's episode. We also put a list of references below this video. So, how can you become the best advocate for your critically ill loved one? How can you make informed decisions, get peace of mind, control, power and influence quickly whilst your loved one is critically ill in intensive care? You will get to that all-important feeling of making informed decisions, get peace of mind, control, power and influence when you download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you will learn quickly how to make informed decisions, get peace of mind, real power and real control, and how you can influence decision making fast whilst your loved one is critically ill in intensive care. Your free Instant Impact Report will give you in-depth insight that you must know whilst your loved one is critically ill or is even dying in intensive care. Sign up and download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you will learn how to speak the secret intensive care language so that the doctors and the nurses know straight away that you are an insider and that you know and understand what's really happening in intensive care. In your free report, you will also discover how to ask the doctors and the nurses the right questions, discover the many competing interests in intensive care, and how your critically ill loved one's treatment may depend on those competing interests. How to eliminate fear, frustration, stress, struggle, and vulnerability even if your loved one is dying. You will get 5 mind-blowing tips and strategies helping you to get on the right path to making informed decisions, get peace of mind, control, power, and influence in your situation. You will get real-world examples that you can easily adapt to your and your critically ill loved one's situation. How to stop being intimidated by the intensive care team and how you will be seen as equals. You will get crucial behind-the-scenes insight so that you know and understand what's really happening in intensive care and how you need to manage doctors and nurses in intensive care, and it's not what you think. Thank you for tuning into this week's Your Questions Answered episode, and I'll see you again next week in another update. Make sure you also have a look at our blog section for more tips and strategies, or simply send me an email to support@intensivecarehotline.com with your questions. Also, have a look at our membership site intensivecaresupport.org for families of critically ill patients in intensive care. You can also call me, find phone numbers on the top of our website. Also, have a look at our ebook section where you get more ebooks, videos, and where you can also get one-on-one consulting and advocacy with me over the phone, via Skype, via Zoom, and via email. Thank you for watching this blog. This is Patrick Hutzel from intensivecarehotline.com, and I'll talk to you in a few days.